as herbal complementary alternative therapies and how best to manage these interactions. And lastly, to identify some tools and strategies that can assist with screening for, identifying, and managing these potential drug-drug interactions. That was weird. Sorry, got to restart the slideshow. Okay, let me try. I'm having a pretty serious computer glitch on my end here. I can't operate the PowerPoint for some reason. Clive, I would suggest for the moment we actually go into discussing the case while I troubleshoot this problem on my end and try and correct it, and we'll come back to the didactic later. Does that work?
We could certainly. Is Dr. Tafari ready? Do you know, Patricia? Yeah. Chris, can we try and do the presentation from here? And you just tell us when to go to the next slide.
Okay, let's try that.
We're going to share our screens.
Okay, next slide. Okay, good. So I would say there are three chief kinds of drug interactions or mechanisms that occur that are responsible for the vast majority of the problematic drug interactions we see. The first and probably most common is one that involves hepatic metabolism. Many of our antiretrovirals are metabolized in the liver by what's called the cytochrome P450 system. And many of our antiretrovirals also either inhibit or stimulate that same metabolism system. And this can be responsible for quite a few drug interactions, which we'll get to. There's another less common one called UGT1A1. The details are not critical to know, but this is the mechanism that can affect our integrase inhibitors. Acid suppressing agents can interfere with absorption, for example, atazanavir and rilpivirine. And then there are certain divalent cations such as calcium, magnesium, aluminum, and iron that can bind to the integrase inhibitors and impair absorption. Next slide. Now, the first one I want to focus on is the way that ritonavir can intensify the pharmacokinetics of other protease inhibitors. So I mentioned the cytochrome P450 system. There's a little diagram of it at the bottom of the slide, which is insanely complicated and nothing you need to really know. I just had space for it at the bottom of the slide and thought it looked nice there. But the bottom line is that is the system that metabolizes many of our antiretroviral drugs from the protease inhibitor class and to a lesser extent the NNRTI class. And there are a number of other prescription medications that are also metabolized through this system. Now, ritonavir is a protease inhibitor for HIV, which was found to be a very, very strong inhibitor of this system. And we've come to use that to our advantage by administering small doses of ritonavir with other protease inhibitors, thereby vastly improving what we call the pharmacokinetic profile. Next slide. So this is an example of of how this works. If you give indinavir on its own, which is shown in the black bar, and you look at the drug levels over time within indinavir monotherapy, you see a high spike in the serum level of indinavir right after you give it, but then it falls off very quickly. And within 8 hours, it's pretty much at negligible amounts in the blood, which is why indinavir needs to be administered every 8 hours, and that's rather difficult to do. On the other hand, if we give indinavir with a relatively low amount of ritonavir, and what we've settled on is the sort of light blue approach shown on the graph, 800 milligrams of indinavir and 100 milligrams of ritonavir every 12 hours, you get a much better pharmacokinetic profile. The peak level of indinavir is not that much higher, but it stays high for a much longer period of time. And that allows for a much more forgiving profile with less frequent dosing, and it's not as problematic if you're a little bit late with the next dose. So this kind of interaction with other protease inhibitors applies to virtually all of the protease inhibitors, and which is why whenever we see protease inhibitors administered, you commonly see ritonavir administered as well at a low dose. We're using the ritonavir not for its intrinsic anti-HIV effect, but really we're using it to increase the potency and simplify the dosing of the co-administered protease inhibitor. Next slide. Now, it's kind of a double-edged sword, though, with the potency of ritonavir in terms of blocking metabolism of other drugs that go through that P450 pathway. For example, this is an example of a patient who was on ritonavir for her HIV at a low dose and was also using inhaled fluticasone for management of asthma. And she developed full-blown Cushing syndrome, which is characterized by very high levels of cortisol in the bloodstream. She developed what we call a buffalo hump. She developed the skin changes that led to secondary infection. And this has been documented in multiple other instances. And you may be saying to yourself, now, wait a minute, this woman was only using inhaled fluticasone. It's the inhalation version is only supposed to sort of stay in the lungs with only negligible amounts getting into the bloodstream. And that is true. When you use an inhaled steroid like fluticasone, you do get only very low levels in the bloodstream, but the inhibition of its metabolism by ritonavir is so strong that you can end up getting toxic levels of it in the bloodstream. Next slide. Now, corticosteroids are not the only class of drugs that can be strongly inhibited and affected by drug-drug interactions. This is actually just a partial list of other drug classes that are commonly involved. They include the acid suppressants, anticoagulants, statins, various cardiac medications, psychiatric medications, antimycobacterial, and selected herbal and complementary alternative meds as well. Next slide. Now, there are insanely complicated tables that try to list all the medications that can interact significantly with our HIV drugs. Here's an example of one that was published by the World Health Organization a few years ago. This table is 14 pages long. I'm just showing a one-page snapshot of it. I don't find these tables terribly helpful in clinical use because they're just too difficult to access when you need them and too difficult to navigate. And moreover, they don't always give you the details you need about the severity of the reaction and what to do about it. Next slide. So I think it's far better to take advantage of online and tools that are much better at navigating these drug-drug interactions for you. And I think the best one out there is one that was developed by the University of Liverpool. It's available online at that URL at the bottom. It's free of charge, and it's really rather simple to use. You simply type in the antiretrovirals in the box at the upper left, and then you search for co-administered medications in the box in the upper middle, and then it gives you a report on the right about what the drug interactions might be. Next slide. So as you may recall from last week, we had a case where there were actually significant drug-drug interactions involving the patient in question who was taking nevirapine as part of her HIV regimen, or his HIV regimen, and was also taking an herbal product called cat's claw. So in this particular example, you type in nevirapine under HIV drugs, you type in cat's claw, and then you click on the check for interactions, and it shows you on that right-hand column what the results are. And in this case, there is a potential interaction. It provides the quality of evidence regarding that call on the potential interaction, and essentially what the reasoning is, what the drugs involved might be, the mechanism. In this case, interestingly, cat's claw, that herbal product, like ritonavir, is a strong inhibitor of that same cytochrome P450 system, and therefore could potentially increase the drug levels of other drugs that are metabolized through that system. And in the end, it recommends co-administration should be avoided. You can also generate a PDF copy of that report that can be included in the patient's chart, for example, which I think is also a nice feature. Next slide. There are app versions of this website, which are also very helpful. This is what it looks like on the iPhone. It's available for free from the App Store. Next slide. And similarly, there is a free app available for mobile devices that run on the Android operating system. And they pretty much operate the same way. Now, in the end, though, using that tool may not be enough. If you have a particularly sort of rarely used medication or a complementary alternative medication, or if you want more detail, you may want to look to the medical literature and see what exactly has been published to date about a potential interaction. And for that sort of thing, I highly recommend Google Scholar. It's a version of Google that specifically searches the academic literature. Next slide. And so last week, I simply, in reviewing that case, went to Google Scholar, typed in cat's claw HIV because I had never heard of the use of this product for HIV treatment. And through the magic of Google's algorithm, it pulls up really, I think, the most relevant articles about what is the background to the use of this herbal product for treating HIV. And it helpfully includes some information also about interactions. Go back, please. Okay, now forward. Next slide. Okay, so just to summarize our key points, drug interactions are common, both between individual antiretroviral drugs, between antiretrovirals and other prescription medications, and between antiretrovirals and various non-prescription herbal alternative medications. And that's due to a variety of mechanisms, primarily those involving hepatic metabolism. It's really just about impossible to memorize and know these drug interactions off the top of your head. It's also, I think, rather difficult to navigate charts that are out there for it. So it's really worth trying to run your patient's drug medication list, along with non-prescribed medications, through a drug interaction tool like the one offered by the University of Liverpool. And that should probably be done before prescribing or changing an antiretroviral therapy regimen, before prescribing a new medication, or if you become aware that your patient has either started a new prescription or non-prescription medication or herbal product. I mentioned just two tools that I think are really quite useful for this exercise. And keep in mind that potential interaction involving really less commonly studied medications or herbal products may require a search of the medical literature. So I'll end there and open it up to any questions or comments.
Thank you, Dr. Behrens. Pardon me, for that very clear presentation and for introducing us to those tools. Any questions from the community for Dr. Behrens?